I want to talk to you about acute strokes as they apply to radiology. One of the main things when you take that first phone call as a workflow coordinator is you need to get certain information from them so that it can facilitate us taking care of the patient as quickly as possible. So the first thing you want to do is make sure that you get a telephone number for the person that's calling you so you can call them back. So part of our protocol with emergence is to get a final result to the referring physician within 15 minutes. So make sure you know who that point of contact is, whether it's a nurse or a physician. You need to have the number and how to get a hold of them quickly, especially as some of these patients, they may deteriorate quickly, and so the ordering physician may not be readily available, so having a nurse's name and number would be helpful to you. The next thing is you want to get a clinical history that's going to help the radiologist make the diagnosis. So a lot of times the findings on the head CT are going to be relatively subtle, and having a history to help us be directed to which side of the body or which part of the brain is going to be very helpful. Clinical histories that you're looking for: numbness, weakness, altered mental status. Those things are going to be generalized symptoms, but if they tell you they have numbness or weakness, see if you can get them to at least localize the side of the body. So whether it's the left or right side, if it's upper or lower extremity, those things are going to be helpful. Strokes in general, we're talking about, with our stroke protocol, we're really talking about the ischemic strokes. There are two types of strokes that occur in patients. The first is an ischemic stroke, so that's where you have a blood clot that's basically occluding a blood vessel to the brain, so the brain's not getting enough blood. And that's what is ultimately going to lead to an infarction, kind of similar to what happens in the heart. The other type of stroke that you can have is what's called a hemorrhagic stroke, so that's where there's actually bleeding into the brain. And the hemorrhagic stroke, even though it follows the same protocol, the treatment options for the two different kinds of strokes is very different. So with the ischemic stroke, the main thing is they want to get a diagnosis as quickly as possible, and that's because the drug that they can give to treat the stroke, they have to give it within 3 hours. So it's called TPA. They can give them IV TPA to treat the ischemic stroke, but it has to be 3 hours. So a lot of times the patient may have been down at their house for an hour, or they had symptoms and they weren't sure if they should go to the emergency room. So part of that 3 hours has already passed. So we want to make sure that the part of that 3 hours that we occupy is as quick as possible. And so most stroke centers will make part of their stroke protocol to get a patient into the CT scanner within 15 to 20 minutes of hitting the door. So if you can imagine, they've spent an outside hour before they came into the hospital. They spent another 15-20 minutes waiting to get the CT, and then another 15 minutes for us to get the report. So we're already pushing in, an hour and a half, maybe even up to 2 hours. So that doesn't give much time for them to get the medication. Once they get past that 3 hour interval, it's not as beneficial to give the TPA, so they really want to do it quickly. In terms of the hemorrhagic stroke, that's where there's bleeding into the brain, and so that's really, we're looking for an aneurysm on the head CT. So certainly that patient is not going to be a candidate for TPA by any means, but what they will be doing is if they have an aneurysm that's bleeding, they're going to get them to a neurosurgeon or to a neurointerventional radiologist that can treat the actual aneurysm and work on the bleeding in that manner. The main thing that we want to do, though, is facilitate getting the results back to the ordering clinician as quickly as possible. Once you get those results from the radiologist, make the phone call, let them know what the results are, and then there's two things that we need to make sure that we get in every report. Number one is the radiologist, if they didn't put that in there, we need to make sure we put the sentence after the impression that says, whether there's a stroke or not, we want to make sure we put in a sentence that says, if neurologic deficits persist, follow-up brain MRI is recommended. And that's for any patient that has stroke-like symptoms. We need to make sure that sentence gets into every single report. So if there are any focal neurologic deficits, recommend follow-up brain MRI. The second thing we want to make sure that we get in every report is that we document at the end of the report who we talked to, when we talked to them, at what phone number we called, so that we have in the report that we've already given the clinician the results and at what time that we gave the results. That way we cover our bases if it needs to be evaluated later. Thank you.